My name is Lynsey Blankenship, and I'm a graduate nursing student at West Texas A&M University. Today I will be conducting a head-to-toe assessment on a 29-year-old Caucasian male who has come in for a general physical exam. Prior to this, we have conducted a general survey, a comprehensive health history including past medical history, surgical history, family history, social history, and review of systems. I have gotten his height, weight, and vital signs, which are all within normal limits. He has no known drug allergies. He doesn't currently take any medications. And I've also tested cranial nerve number 2, the optic nerve, with the Snellen E chart. He has 20/20 vision bilaterally without corrective lenses. I've washed my hands, and now I'm going to go ahead and start my head-to-toe assessment. So first I'm just going to do a general inspection of the head and the neck. I'm looking at the scalp, making sure I don't see any type of dandruff, lice. I'm going to make sure I'm not feeling any lesions, bony prominences, that his skull is nice and intact. I'm going to palpate his temporal pulses, making sure that they are 2+ bilaterally, which they are. And I'm going to palpate his frontal and his maxillary sinuses, making sure that there isn't any tenderness there. Next, I'm going to test cranial nerve number 5, the trigeminal nerve. I want you to close your eyes and tell me if you feel sharp or dull.
Dull. Dull. Sharp. Dull.
Great. I'm just doing a general inspection, making sure his eyes are symmetric, his ears are symmetric, his nose and his mouth are midline, which they are. And I'm going to go ahead and test his temporomandibular joint. I'm going to have you open your jaw. I'm going to place my fingers, which 2 to 3 is normal. I can fit 2 back here. Close your jaw and move it from side to side. Great. And I'm just making sure I don't feel any type of clicking, which I don't. So now I'm going to go ahead and assess the eyes. I am going to check pupillary response, direct and consensual. So I'm going to test direct and consensual, indirect and consensual. Great. And now I'm going to go ahead and test for accommodation. I want you to look at this pen light and look at the back wall, and then at this pen light and at the back wall. Great. Next, I'm going to test cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens. I'm going to do this with the 6 cardinal fields of gaze. I'm going to have you look at this pen light without moving your head. Great. Now I'm just making sure I don't see any type of jerky eye movements or nystagmus, which I don't. So now I'm going to go ahead and take a look inside the eye. I want to look at the optic disc and the red reflex and make sure that there's no abnormalities or papilla edema. So I'm going to do this, and I'm going to place one hand to embrace on your forehead. Great. Everything looks normal. So now I'm going to move on to your ears. I want to palpate your ears, making sure I don't feel any type of nodules, which I don't. And I'm going to do a slight tug test, making sure he doesn't have any type of tenderness before I look inside. Is that tender?
No.
Great. So as I look inside, I want to check the tympanic membrane, making sure it's a pearly gray color and that there isn't any type of redness or inflammation. I'm going to pull up and back on his pinna since he is a male adult. If it was a child, I would pull down and back. Great. So I'm now going to test cranial nerve number 8, the vestibulocochlear nerve. I'm going to do this with the whisper test. Can you repeat what I say?
66. 55.
Great. I'm also going to perform 2 other tests, the Weber and the Wren test. The Weber test tests lateralization, making sure that he hears evenly in both sides. So tell me if you hear this left, right, or mid.
Mid.
Great. And now to perform the Wren test, this tests air-to-bone conduction. So tell me when you stop hearing this.
Okay. Okay.
Great. So that is a 2-to-1 ratio, which is normal. So now I'm going to move on to the nose. I'm going to look at the nose, making sure there's no septal deviation, and I want to check patency. So I'm going to occlude one there and make sure he can breathe in and out. And the other? Great. I'm also going to test cranial nerve number 1, the olfactory nerve. So I'm going to occlude your nerves in each side and have 2 different smells. So tell me what you smell, okay?
Rubbing alcohol. Peppermint.
Great. Now I'm going to go ahead and take a look inside. I'm going to have you look up for me, and I'm going to look for any type of ulcers or nodules. Great. Everything looks normal. So now I'm going to move on to the mouth. I'm looking at his lips, noting that they're nice and pink. I'm going to take a look inside, making sure that his he has nice pink moist mucosa, and that his soft and hard palate are normal, which they are. I don't see any type of cancer lesions. If you can lift your tongue up for me. There's none under here. Vascularity looks good. And then I'm going to go ahead and test cranial nerve 9 and 10, the glossopharyngeal nerve and the vagus nerve. So I'm going to do this by having you say "ah." Great. His uvula looks nice in midline, and then I'm going to test his gag reflex. Great. So now I'm going to have you protrude your tongue out and gently move it side to side, slowly. Great. I'm making sure there's no cancer lesions hiding on the sides of the tongue, and I'm also checking cranial nerve number 12, the hypoglossal nerve. Now I'm going to test cranial nerve number 7, the facial nerve. If you could smile for me and puff your cheeks out. Great. And I'm going to test cranial nerve number 11. I'm going to have you shrug your shoulders up against me and down. Great. That is the spinal accessory nerve, cranial nerve number 11. So now I'm going to move on to the neck. I'm looking at the trachea, making sure it's nice and midline, and I am going to go ahead and palpate his carotid pulse. I'm going to do that separately with each of my fingers, making sure they are 2+ bilaterally, which they are, and then I'm going to listen with both sides of my stethoscope as he takes a big deep breath and make sure I don't hear any bruise. So take a big deep breath for me. Hold it. Let it out. And one more time. Hold it. Great. So now I'm going to assess the thyroid. I'm going to do this by going behind the patient, placing one hand on each side and having him swallow. I'm making sure there's no type of enlargements or goiters, which there isn't. And I'm going to go ahead and palpate the lymph nodes. So I'm going to palpate preauricle, postauricle, submandibular, submental, cervical, postcervical, supraclavicular, and then I'm going to go ahead and assess the axillary. I'm making sure that they aren't tender and there's no swelling there, which there isn't. And now I'm going to go ahead and assess range of motion of the neck and strengthen the neck. So if you could put your ear to your shoulder without moving your shoulder up. Other side. Look up for me. Look down. Great. Now press your face against my hand. This side. Awesome. So now I'm going to have you turn around. I'm going to assess your posterior thorax. So I'm taking a look at his breathing, making sure that it's not labored. He has equal and even rise and fall of the chest. Doesn't look like he has any type of breathing difficulty. I'm going to test a chest expansion by placing my hands and having him take some deep breaths. I'm watching my thumbs, making sure that they rise and fall evenly, which they do. And I'm going to go ahead and palpate for tactile fremitus. Say 99 every time I touch you.
99. 99.
Great. And I'm going to go ahead and assess for costovertebral tenderness. Tell me if this is tender. So next I'm going to percuss the lung fields. I want to make sure that they are resonant, they aren't dull, which could indicate fluid in the lungs, and they aren't hyperresonant, which could indicate overexpansions such as COPD. I'm going to do this in a ladder-like motion. Great. And I'm going to also check diaphragmatic excursion. So I'm going to have you take a deep breath and hold it. I'm going to percuss up until I hear dullness. I'm going to mark that, and then I'm going to have you breathe out. And I'm going to percuss until I hear dullness, measuring the 2 points in between, and it should be about 3 to 5 centimeters. So now I'm going to go ahead and also take the lungs. I want to make sure that there aren't any adventitious breath sounds such as crackles, wheezing, rough eyes. So take some deep breaths for me. Great. Sounds nice and clear. So now I'm going to have you go ahead and sit on the side of the bed. I'm going to check the anterior thorax, and I'm going to note the AP diameter, making sure that he is not barrel-chested, which he isn't. That could indicate COPD. I'm looking at him. I can tell that he's not using any accessory muscles. He's not retracting. His breathing looks normal. I'm going to go ahead and test for lung expansion on this side, and I'm going to have you take a deep breath. Great. One more time. And tactile firmness. Say 99.
99, 99, 99, 99.
Great. I'm going to go ahead and palpate for thrills and heaves with the ball of my hand and the pads of my fingers. I'm going to go ahead and feel for the point of maximum intensity. I'm able to feel it. Typically, it's at the 5th intercostal space midclavicular line. Now I'm going to go ahead and percuss the anterior lung fields. I want to make sure, again, they're resonant, not dull, not hyperresonant. Ladder-like motion again. Great. And I'm going to also take anteriorly, making sure that his lung fields are clear. Deep breaths. Great. So next I'm going to assess the heart. I want you to lean over slightly. This brings your heart a little bit closer to the anterior thorax. And I'm going to be listening to several heart sounds. Second intercostal space, right of the sternal border, that is the aortic. Second intercostal space, left of the sternal border, pulmonic. Second intercostal space, third intercostal space, left of the sternal border is Erb's point. Fourth intercostal space, left of the sternal border is tricuspid, and fifth intercostal space, midclavicular line, is the apex of the heart, the mitral valve. So I'm going to listen with both sides of my stethoscope. I'll listen lastly with the bell, making sure there's no murmurs. Now with the bell. Great. So now I'm going to have you lean back. I'm going to check your jugular venous pressure. So I'm going to lay you back at about 30 degrees. I'm going to note the highest point of the meniscus of the external jugular vein. And I'm going to note that pulsation. And then I'm going to get a centimeter ruler, placing it at the sternal angle. And I'm going to get something flat, such as an index card, a piece of paper, and I'm going to measure. And it should be about 3 to 4 centimeters above the sternal angle, which his is 3 centimeters, which is normal. So now I'm going to go ahead and lean him back and assess his abdomen. I'm going to go ahead and uncover you. I'm going to inspect your abdomen, making sure I don't see any type of umbilical hernia, ascites, any kind of abnormalities or masses, and I don't. So next I'm going to go ahead and auscultate. I'm going to also take all 4 vowel sounds, making sure they're not hyper or hypoactive. And then I'm going to go ahead and also take the aorta and the femoral pulses. I'll do those with both the diaphragm and the televised stethoscope to make sure that I don't hear any bruits. Now I'll be listening to the aorta and with the bell. Now the femoral arteries and with the bell. Great. So next I'm going to percuss the abdomen. I want to make sure to know any type of dullness, which could be an organ or it could be a full bladder. To percuss the liver, I'm going to go right of the umbilicus, mid-clavicular line, and percuss up until I hear dullness. And then I'll go right below the nipple, mid-clavicular line, down until I hear dullness, and I'll measure between those 2 points. Now to percuss the spleen, I'll go to the left upper quadrant, making sure I don't hear any type of dullness, which I don't. And then I'll do some light palpation, pressing on the patient's abdomen, making sure he's not grimacing, and there's no tenderness, no mass is felt. And then I'll go ahead and start with my deep palpation. So I'll put my left hand underneath the patient's back, have the patient take a deep breath, and I'm going to feel for his right kidney. Great. And his left kidney. Deep breath. Great. Now I'm going to palpate for his liver. So take a big deep breath. Great. And I'm going to go over here and attempt to palpate his spleen. Sometimes the spleen is unable to be felt, which is normal, so take a deep breath. I'm unable to feel the spleen, which, like I said, is normal. So now I'm going to go ahead and cover you up, and I'm going to have you still lay back. Sorry. And I'm going to lift your leg, dorsiflex your foot. Does that hurt?
No.
Great. That would just indicate a herniated disc. Lift up your leg, dorsiflex. No pain?
No pain.
Great. So now I'm going to go ahead and test range of motion of the knees and the hips. I'm going to do this simultaneously and bilaterally. So I'm going to lift. Your leg is extended. I'm going to flex it. I'm going to internally rotate. I'm going to externally rotate. I'm going to abduct, and I'm going to adduct. Great. Same with the other leg. Your leg is extended. I'm going to flex it. I'm going to internally rotate. I'm going to externally rotate. I'm going to abduct, and I'm going to adduct. Great. Now I'm going to check range of motion of your ankles by dorsi and plantar flexion of the feet. I'm going to have you push up against my hands. This tests strength as well. Great. And down. Great. Now I'm going to have you go ahead and sit up on the side of the bed. I'm going to test range of motion of your shoulders. So I'm going to have you abduct, adduct, externally rotate, and internally rotate. Great. Now I'm going to have you extend your elbows, flex your elbows, and test strength. Pull against me. Great. So now I'm going to go move on to your wrists. I'm going to have you pronate and supinate your hands. And if you can do that quickly, this tests cerebellar function with rapid movement. Great. Now I'm going to go ahead and test stereognosis and graphesthesia. And I'm going to do this by having you close your eyes. And I want you first to recognize the number that I am drawing in your hand.
7. 8.
Great. Keep your eyes closed. I'm going to place 2 objects in each of your hand individually. I want you to tell me what these objects are.
Coin.
Great.
Keys.
Great. Now I'm going to test strength of, you can open your eyes. I'm going to test strength of your hand by having you grab my hands. Awesome. And now I'm going to test point-to-point movement. I'm going to do this by having you close your eyes. I'm going to point to one of your fingers and you tell me, or you place that finger on your nose. Great. And now with your lower extremities, this is point-to-point movement as well. I want you to run your shin your heel up and down your shin, each side. Great. So now I'm going to move on to the lower extremities. I'm noting the color of his extremities. I'm making sure that he has even hair distribution, that he doesn't have any type of edema, no varicose veins, and then I'm going to go ahead and assess his pulses. So I've already done the carotid and the temporal, and I'm going to do the brachial. And I'm going to do the radial, making sure they're 2+ bilaterally, which they are. I'm going to do the popliteal with both my hands on each side. Posterior tibialis and dorsalis pedis. They're all 2+, which is great. Now I'm going to go ahead and assess his reflexes. So I'm going to assess the triceps reflex. I want you to relax your arm for me. Great. Let's do this side so that they can see. Great. And I'm going to test your brachial. Brachial. Great. And your brachial radial. Great. Your patellar. So I'm going to make sure that your leg is relaxed, not on the floor. Great. And your Achilles. Great. All of that looks normal. So now I'm going to have you go ahead and stand up. Sit back down for a second. I'm going to test proprioception, the test cerebellar function of your toes. So I want you to look straight ahead and tell me if I'm moving your toes up or down.
Up. Down.
Great. So now you can go ahead and stand up. I'm going to do something called the Bromberg test. If you could close your eyes. And I'm just making sure his balance is normal. He's not swaying, which he isn't. And then you can open your eyes. You feel okay?
Mm-hmm.
Great. So I'm going to have you go ahead and touch your toes. And I'm just assessing his spine, making sure there's normal curvature, no abnormal lumps, and there's no signs of scoliosis, which there isn't. If you could lift halfway up for me, I'm going to assess it again. Great. So now I'm going to go ahead and assess his gait. I want to make sure that his muscle coordination is good, so I'm going to have him do some tandem walking. I'm going to have you walk heel-toe towards the camera. Great. And then if you could walk all on your heels, and then back to me, all on your toes. Great. So that concludes the head-to-toe assessment. As I assessed him, I didn't know any abnormalities of the skin. I didn't note any abnormal freckles, any abnormal hair distribution or moles, lesions. I made sure he didn't have any clubbing on his hands and his fingers, and that his nails were pink. There wasn't any cyanosis. So now I'm going to go into a discussion of the proper techniques for female and male genitalia exam, rectal exam, prostate exam, and breast exam. So before I would do any of these, I would tell the patient exactly what to expect, making sure that they were aware of what I would be doing, and that they would be properly covered, preserving any type of dignity. And then with the female, as I would assess the female genitalia, male genitalia, and breasts, I would stage them on the Tanner staging scale. And so with a female genitalia exam, I would place her in the lithotomy position. I would grab all my supplies, this proper size speculum, proper lighting, and the proper lubrication. I would look at the external labia minora, the clitoris, the urethra, the vaginal opening, and make sure there wasn't any type of abnormal discharge, no swelling, no irritation or ulcerations. And then I would place the speculum inside, inspecting the cervix, making sure that it was a normal color. Again, there wasn't any abnormal bleeding, abnormal discharge. And as I took the speculum out, I would note the internal vagina, any type of redness, ulcerations, abnormal discharge, anything like that. Then I would perform a bimanual exam. I would do this with my index and my middle finger, and I would palpate the cervix. I would then place my other hand on the abdomen to palpate the uterus and to palpate each ovary. I would also have the patient bear down, and so I could feel the strength of the pelvic floor muscles. With the male genital exam, I would have him either supine or standing. I would inspect the penis, the skin, making sure that everything looked normal. If the patient had foreskin, I would make sure it was retractable. There wasn't any hidden ulcers, any scarring, redness, anything abnormal like that, any abnormal discharge. Then I would palpate the shaft of the penis between my thumb and my 2 fingers, making sure there wasn't any induration or tenderness. I would inspect the scrotum, making sure there wasn't any type of swelling, any nodules, any abnormal hair distribution, and then I would palpate each testy in between my thumb and my 2 fingers individually. I want to make sure that each testy is descended, that they're symmetric, that they're firm but they're not hard, they're not tender, and that there aren't any abnormal nodules. And then with the rectal exam, if it was a female, I'd have her in lithotomy. If it was a male, I would have him on his left side with his knees and hips flexed. I would place my gloved finger inspecting the outer sacral and perianal area, making sure there wasn't any abnormal rashes or irritations. I would inspect the anus and the rectum, making sure there wasn't any hemorrhoids, no ulcerations, and then I would have the patient bear down. I would insert my gloved lubricated finger, and I would palpate the rectal surface clockwise and then counterclockwise, making sure there wasn't any type of nodules or induration. And then with the prostate exam, I would palpate clockwise and counterclockwise to make sure I feel the posterior surface of the prostate, and I want to make sure that it feels normal, which is rubbery, non-tender, and there aren't any nodules. With the breast exam for a female, I want to make sure that I inspect that the breasts are symmetric. I want to inspect with her hands over her head, on her hips, and leaning forward, making sure there's not any dimpling or retractions. When I palpate the breast, I want her to be supine. I want one hand to be on her forehead, and I'm going to use my 2nd, 3rd, and 4th pads of my fingers and go in a vertical strip pattern. And I just want to make sure that I'm palpating the entire breast, including the axillae, making sure I'm not seeing any type of abnormal nipple discharge or any type of abnormal lymph nodes. And with a male, I'll have him sitting, and I just want to inspect the breast, making sure that they're symmetric, the nipples are symmetric, there's, again, no abnormal nipple discharge, that the breasts aren't enlarged, like he doesn't have gynecomastia or anything like that. And then when I palpate, I want to make sure and palpate the left and right axillae as well, and I want to make sure that there isn't any enlarged lymph nodes that are greater than 1 to 2 centimeters or any type of lesions of any kind. And that concludes my head to toe assessment video.